Hello, everyone. My name is Chris Bondis, Head of Marketing at PatientPing, and I'm thrilled to welcome you all to our CMS Interoperability and Patient Access Rule e-notifications condition of participation webinar. As you likely know, CMS published the rule to the Federal Register on May 1st, and hospitals have 12 months from that day to comply with the new e-notifications condition of participation. The deadline certainly got people's attention, as several hundred hospitals of all sizes across the country have joined today's webinar. Thank you all for taking the time to join us. Before we dive into today's conversation, I'll be covering a few technical logistics. First, attendees will remain muted throughout the webinar. We will have a Q&A portion at the end where you will be able to submit any questions via the GoToWebinar control panel simply by clicking the question mark icon on the right-hand side. We will try to answer as many questions as possible, but if we can't get to all of them, we will certainly follow up with any of you whose questions were missed. A copy of the webinar recording will also be sent to all of you shortly after the session. With that said, I am pleased to introduce our speakers. First is Vanessa. Vanessa is PatientPing's Director of Policy, and she possesses nearly 15 years of experience in both the public and private health sectors. Prior to PatientPing, she was a program officer at the CMS Innovation Center for the Pioneer ACO model, and subsequently was the director of the LifeBridge Physician Network. She was also the Chief of Performance Improvement at Behavioral Health Systems in Baltimore. Vanessa earned her PhD from Johns Hopkins University in Health Policy and Management. Kirsten is a Senior Product Manager here at PatientPing, and before joining PatientPing, she held marketing, new product planning, and market access pricing roles at Sanofi Genzyme and worked as a healthcare management consultant at Putnam Associates. Kirsten holds an MBA from the MIT Sloan School of Management and a BA from Middlebury College. Vanessa, over to you.
Great, thank you, Chris, for the introduction. I'm excited to get us started today and to have so many of you join us for today's webinar. I know everyone is extremely busy, so we want to make this next hour valuable and give you all of the information you need to understand the new Hospital Condition of Participation, or COP, that CMS recently finalized. So with that in mind, our goals for today are to set the context for the CMS Interoperability and Patient Access Rule and dive into the details of the new e-notifications condition of participation requirements. I'll also highlight the key considerations you need to take into account to make important assessments and decisions about your readiness to meet those requirements. And then my colleague Kirsten will provide additional details about how you can comply with the COP using the PatientPing route solution. And as Chris already mentioned, we'll end the session with Q&A. So to provide a little bit more context, over 2 months ago on March 9th, two significant and complementary health IT rules were finalized that I'm sure you all have heard about. The ONC Cures Act, or the info blocking rule, and the CMS Interoperability and Patient Access Rule. Really, both rules focus on information sharing, making data more accessible to patients, and ensuring data can be readily exchanged to improve patient care and outcomes. Today, we'll focus on the CMS rule. That rule contains multiple final provisions, one of which, Section 10, is the e-notifications condition of participation, our specific focus for today. Many of you know, especially if you work in compliance, that conditions of participation are the most significant and consequential regulatory lever that CMS has, as COPs determine a hospital's certification status and its ability to receive CMS payments. COPs are those requirements that get audited by your state survey agencies and accreditation organizations. And if you're not compliant with all COPs, it can jeopardize your standing with CMS and your certification status. So really, it'll be very important to meet and comply with these requirements. As Chris mentioned, CMS published this final rule on May 1st in the Federal Register and included a 12-month implementation timeline for being compliant with the new COP. So I want to spend a minute just on the intent of the rule, as it's important for the context and really understanding all of the requirements that are included in the COP. While, of course, some information sharing is already occurring across different locations and regions, CMS drafted the COP as a way to accelerate that information sharing with the intent of improving patient outcomes and to give non-hospital providers access to needed information. So while existing mechanisms and structures to share that information are good, they're clearly not fully sufficient to realize these goals. Otherwise, CMS wouldn't have needed to put a new COP in place. As stated in the final rule, CMS recognizes that hospitals are critical to seamless care transitions and that more information enables better care coordination and ensures better outcomes. With the new COP, CMS hopes to support information sharing across the care continuum and also ensure that information is available to providers for treatment, care coordination, and quality improvement activities, and to eliminate any remaining or existing barriers to information sharing. So again, the takeaway here is that CMS created the COP to improve cross-continuum coordination and to help eliminate any barriers for information sharing. Let's now jump into the actual COP and associated requirements. At a high level, the new requirements are as follows. Hospitals must make a reasonable effort to send admission, discharge, transfer, or ADT notifications to post-acute providers, primary care practitioners, practice groups, and entities that need the information for treatment, care coordination, or quality improvement activities. So as mentioned, the compliance deadline is 1 year from the publication date, which will be May 1st, 2021. So we'll dive into the details of the requirements in the following slides. Let's take a more detailed look at what the basic requirements actually are. The final rule requires that e-notifications be sent by hospitals, psychiatric hospitals, and critical access hospitals at inpatient admission, discharge, and transfer, and also at ED presentation and discharge. And those notifications will need to go to the following recipient types: established primary care practitioners, primary care practice groups and entities, applicable post-acute providers and suppliers, and then also other practitioners and groups or entities that are primarily responsible for the patient's care. And those messages also have to contain, at a minimum, the patient name, treating practitioner name, and defending institution name. We'll now dive even a step further into the details of these requirements. So let's first talk about who is actually required to comply. The COP applies to hospitals, psychiatric hospitals, and critical access hospitals, as I just mentioned. Now, of those, only hospitals that use EMRs or other electronic administrative systems that have the capacity for notifications conformant with the HL7 2.5.1 standard will be subject to the COP. Pretty much every EMR has that capability, so most hospitals will be included here. We noted in the slide the specific Code of Federal Regulations subsection for each hospital type where the new COP will be inserted. They'll be part of the medical or the clinical record requirements. So again, what you need to know is that the COP will apply to hospitals, psychiatric hospitals, and critical access hospitals that have the operational systems with the capacity to send notifications. So now that we have understand what hospitals are subject to the COP, let's talk more about the actual notifications. As mentioned, notifications must be sent at the point of inpatient admission, discharge, and transfer, and also at ED presentation and discharge. The ED requirement was newly added as part of the final rule based on feedback CMS received to the proposed rule. And then notifications about the internal hospital floor or unit transfers are not required under the COP, but are certainly allowed to be sent, but again, not a requirement. So we've identified the event type that triggers the notification requirements. Let's talk more about the notification process itself. First, notifications can be sent directly by the hospital to the recipients or by an intermediary. Second, notifications have to be sent in near real time. Per the final rule, notifications must be sent, quote, at the time of the patient's registration in the hospital's emergency department or at the patient's admission, et cetera. That indicates really the real-time nature of the notification requirement. So again, at the time that the event occurs will trigger the notification. The message must include, at minimum, the patient name, the treating practitioner name, and the sending institution name. CMS had originally proposed to also include diagnosis information, but that is no longer a required data element. A diagnosis is, however, optional as long as it's permissible by applicable laws and regulations. In general, I should note here that CMS made clear that the e-notifications requirement will apply where permissible under federal and state laws and regulations and as consistent with the patient's privacy preferences. And finally, there is no specified format of how notifications need to be delivered. So again, takeaway here about the notifications themselves is that they must be sent in real time at the point of inpatient admission, discharge, and transfer, and at the ED presentation and discharge, and can be sent by the hospital directly or by an intermediary. So we talked about which hospitals have to send notifications and what those notifications must include. Now let's turn to the actual recipients of those notifications. There are three different categories. The first category of recipients is the established primary care practitioner, practice group, or entity. These can be primary care providers, primary care physician practices, FQHCs, and entities like accountable care organizations where PCPs drive primary care patient assignment and have specifically delegated care coordination activities to that entity. The second category is practitioners, practice groups, or entities that the patient identifies as primarily providing his or her care. This is something the patient can specify at the point of care. And these recipients could also be PCPs, specialists, community-based mental health clinics, multi-specialty groups, and others. And finally, the third category is applicable post-acute providers and suppliers that transfer patients to the hospital and those that receive patients upon hospital discharge. There can be skilled nursing facilities, home health agencies, or other post-acute providers. CMS also clarified that recipients are those that need notifications for treatment, care coordination, or quality improvement activities. So we talked about what hospitals are impacted, the details about the notifications, as well as the recipients. I want to address one other point that we brought up several slides ago, namely CMS specified that hospitals have to make a reasonable effort to send notifications. Now, what does that mean? While the interpretive guidelines are still being drafted, we can use CMS's responses to comments in the rule, the finalized requirements, and the intent of the rule to credibly define what that might mean. So at a basic level, reasonable effort means that hospitals will need to demonstrate meeting the minimum requirements in the rule. Those minimum requirements are sending all the required notification types that we talked about in real time to the specified recipients that need the information for treatment, care coordination, or quality improvement activities. That also means knowing who those recipients are is something the hospital or its intermediary will need to determine. As we discussed, some practitioners may be identified at the point of care by the patient, and which can address some of the required recipient types. For example, those established primary care practitioners or those that the patient specifies as primarily providing their care. However, hospitals will also have to make a reasonable effort to send notifications to other applicable recipients as part of that basic requirement. And as we saw in the last slide, mainly those post-acutes and other practice groups or entities with established care relationships that need the information for the specified purposes. Those recipients may often not be determined through the point of care, but still need and are eligible to receive notifications for their patients. As you can imagine, some of those recipients may be located across state lines or in different geographic areas, given that many patients seek care at specialized tertiary hospitals outside their immediate community, or might reside in different states over the span of a year. For example, Medicare snowbirds or sunbirds that have different providers in each location. While hospitals may not reasonably be able to determine proactively on their own the whole universe of those recipients, there is still a need to meet the minimum requirement of sending notifications to those that actively need them for treatment, care coordination, or quality improvement activities, and that haven't opted out of receiving those notifications. So to do that most efficiently and in the least burdensome, and arguably in the most reasonable way, is for hospitals, either directly or through their intermediaries, to implement policies, procedures, and systems that can both respond to notification requests from the eligible recipients made on behalf of their patients, and that can also demonstrate that notifications can be sent to those recipients. In that way, hospitals can credibly demonstrate and fulfill notifications are indeed sent to the set of specified recipients that we have specified within the rule, and through that, check that compliance box. Of course, we would all agree it's reasonable for patients to forgo delivery of notifications to recipients that don't want to receive notifications or don't have the capability to receive notifications, or where there's not enough information available to establish the identification of the recipient. On the flip side, the following would not be deemed reasonable effort. First, failing to put processes and systems in place to meet the basic notification sending requirements to meet applicable recipient needs, which we just extensively talked about. Second, systematically excluding a set of recipients, for example, never sending notifications to post-acute. And third, long or indefinite delays of notification response. CMS will consider further clarification on that as stated in the response to comments in the final rule. To summarize then, to demonstrate reasonable effort, hospitals will need to meet the basic requirements outlined in the final rule, and also demonstrate through their policies, processes, and systems that notifications are sent to all those that are designated as the eligible recipients and that need the information for treatment, care coordination, or quality improvement activities. So based on what we just talked about, there are two capabilities that hospitals or their intermediaries have to meet. The first is that hospitals need to be able to send patient-directed notifications to individual providers. That means PCPs and other patient-identified practitioners. And second, hospitals have to be able to respond to requests from post-acute and primary care groups for notifications on behalf of the patients with whom they have an established care relationship. So let's dive deeper into these two capabilities. For the first capability, the patient-directed notifications, that requires a process where patients identify their providers, which is probably something that you already have in place as part of your registration process. Now, sending those notifications to PCPs and other patient-identified practitioners requires access to a directory of providers' digital contact information, as well as a mechanism to push direct notifications to correctly match providers, and doing that in real time. So having the ability to send notifications to the patient's identified provider is what you need as far as the capability goes for this element of compliance. For the second capability, the provider requested notifications, hospitals will need the ability to respond to the request from many different types of community providers, as we discussed. Managing and fulfilling these requests can again be accomplished by the hospital directly or through an intermediary. This can involve numerous complexities centered around executing data share agreements, processing diverse roster types or patient panel or census lists, and managing frequent and real-time changes as provider-patient relationships change often, especially in the post-acute landscape. So again, the takeaway here is that hospitals or their intermediary need ways to manage and respond to many different provider requests, which often proves to be a complex process. Now, to bring these requirements and capabilities together and to be ready for the surveys, I wanted to just spend a minute on the actual survey process itself. We know from the final rule that the e-notification requirements will be part of the Medical Record Services COP for hospitals and psychiatric hospitals, and the clinical records for COP, and the clinical records COP for critical access hospitals. Based on the procedures that are outlined in the State Operations Manual for that Medical Records Services COP, the survey will include two main components. The first is a review of the organizational structure and policies and an interview, and the second is a records review. For the first part, the policies, hospitals need documentation that explains how hospitals meet the notification requirements and what the procedures are to do so. For the records review, you'll need to be able to show through something like an audit report that notifications have been sent to the specified recipients for those randomly selected patients that are under review. The survey team will formally document any deficiencies on Form 2567. And as I'm sure you're aware, hospitals will need to address deficiencies within the timeline that is specified in the CMS termination procedures. That means hospitals have 10 calendar days to submit a corrective action plan, so the ability for rapid remediation will be essential should you not meet those compliance standards. As the takeaway here, you'll need to have policies in place and the right documentation, such as an audit log, to demonstrate that you meet notification requirements to be ready for the surveys. This wraps up the requirements, and to bring it all together, I want to just review some of the critical considerations you need to keep in mind as you determine how your hospital will meet the new COP. In particular, as you evaluate solutions, you should consider and ask how the solution will meet these 8 points. So let me briefly walk through them. First, consider how you will identify and send notifications to post-acute providers, and how you will send notifications to cross-regional providers who are eligible to receive notifications and need them for treatment, care coordination, or quality improvement activities. You should consider how you will manage and ensure you have the appropriate data sharing rights, security, and trust in place between you and those recipients. And you should also assess how you'll ensure that notifications are actually sent in real time and are not unnecessarily delayed or batched. We talked about this quite a bit, but consider how you will manage and fulfill continuous provider-patient relationship changes and manage the many endpoints of where notifications need to go. And what we just talked about, what will you use to demonstrate compliance once you get surveyed? What will help you get that peace of mind? And now something we actually haven't talked about, but is very important to consider, how will you ensure that community-based providers, those notification recipients that are receiving your information and that want and need the notification from your hospitals, how do you ensure that they have an optimal and excellent experience in this whole process? You rely on those providers for referrals, you send your patients to them for ongoing care, and you want your brand to lead in the market and be a good partner. These cross-continuum partnerships and provider relationships are critical for patients' experience and their care. So making sure the COP actually helps the overall information sharing efforts and making sure that other providers have a positive experience in all of this will be critical and can set your hospital apart from others. Finally, you'll of course need to consider how you will meet compliance by the May 1st, 2021 deadline. While it seems a while away, considering either contracting with an intermediary or building systems internally and getting notification live can take some time, especially if you have other I'm not sure if you caught that, but I was going to hand it over to my colleague, Kirsten, and she will take it away and talk about PatientPing routes. So Kirsten, if you can hear me, please take it away.
Thanks, Vanessa. As my colleague Vanessa just outlined, hospitals need to weigh a lot of key considerations when determining their strategy for how they will comply with the e-notifications condition of participation. Hospitals will have to weigh whether they want to build the required compliance infrastructure in-house or partner with a third-party intermediary to outsource compliance. For those hospitals that do choose to outsource compliance to an intermediary, it will be important for hospitals to feel confident that their intermediary will be able to ensure their full rule compliance by the May 1st, 2021 deadline. We here at PatientPing feel we are uniquely suited to be hospitals' compliance vendor of choice for the e-notification COP, and that starts with our network. We have the most robust national ADT network across the care continuum, composed of over 1,000 hospitals and 5,000 post-acute care sites that rely on PatientPing to send their e-notifications to their care partners in their local care ecosystems today. Our national network contains vast amounts of both post-acute providers and primary care groups, both of which are required recipients for notifications under the COP. Our network also covers a large patient population, with over 43 million patients on the network nationally, and over 135 million patient ADT events processed over the company's 7-year history. In addition to our network, there are a couple of other key pieces of our business that make us a clear preferred vendor for the e-notification COP compliance. We have a superior patient matching algorithm with a 99.99% match rate certified by ONC to make sure that patient data is sent to the right providers who have established care relationships with patients seen at your hospitals. We also have a scalable process that can handle the required volume of real-time e-notifications that will need to be sent across the country in accordance with this COP. Additionally, we have a streamlined onboarding process with no software to install or upgrades necessary. Implementation will only require a few hours of time from your internal IT teams. In sum, PatientPing is a clear COP vendor of choice for compliance due to our robust network and our complementary, scalable, and streamlined process. We just talked a lot about the strength of our national ADT network, but what mechanism will PatientPing ensure hospital partners are compliant with the e-notifications COP? This introduces PatientPing Route, a single solution that guarantees e-notification COP compliance. There are 4 main components of Route in regards to compliance. By sending us your hospital's ADT data, you will immediately attain compliance for the largest aggregation of valid community provider requesters in the country, the greater than 1,500 post-acute providers and primary care groups who rely on PatientPing to receive e-notifications today. To achieve compliance for community providers currently outside our national network, we offer our requester portal, where PatientPing will validate and manage all incoming requests for notifications from community providers. For required notifications to patients' PCPs or other patient-identified providers, we offer a direct messaging service for compliance. Finally, we offer a full audit trail of all e-notifications sent for security and CMS survey peace of mind. Over the next couple slides, we'll dive a bit deeper into each of these 4 route components. By just contributing your hospital's data to the PatientPing network, you will satisfy compliance for the largest collection of community provider e-notification requesters in the country. Over 1,500 community providers representing over 11 million patients rely on PatientPing to receive their e-notifications today. That includes over 300 ACOs, POs, and other care groups, representing over 23,000 PCP practices, over 590 skilled nursing facilities, 470 HHAs, as well as additional hospice, LTAC, specialty, and other providers. In sum, simply just by contributing your data to PatientPing, you'll achieve compliance for likely your largest chunk of required community provider recipients under this new COP. We recognize that you may partner with or treat patients affiliated with community providers who currently aren't on our national network. To support compliance for these providers, we offer our requester portal. The requester portal is a digital asset that can be embedded into your public and provider-facing websites. PatientPing will validate all inbound requests and manage the complexities associated with signing data share agreements and provider roster processing to enable real-time e-notifications to be sent to these requesting community providers. Community providers who submit requests via the portal have options for how they want to receive their e-notifications. They can choose to receive their notifications just from your hospitals via our direct ADT web app, or they can choose to upgrade to our industry-leading PINGS product to receive notifications for when their patients receive care at your hospitals, plus the other 1,000 hospitals and all the other post-acute care sites on the PatientPing national network. The required real-time notifications that must be sent to patients' PCPs or other patient-identified providers are sent with a direct messaging component of Route. Patients identify their PCP or any other provider they deem as being primarily responsible for their care during their hospital encounter. Once that information is recorded in the hospital EHR, that data will be included into the ADT feed sent to PatientPing. When PatientPing receives that ADT data, which now includes the identified PCP or other provider information, we look up that PCP's or other provider's MPI and our own proprietary directory, as well as our partner directories, to return that provider's direct message address. Once that direct message address is matched, then notifications will be sent in real time to the identified PCPs or other providers. Now, PCPs or other providers can opt out of receiving direct messages if they simply do not want notifications or wish to consume notifications in a different manner. Finally, Route includes audit reporting with a full audit trail of all e-notifications sent. Our audit report can be used by your internal teams during CMS surveys for random patient record reviews. Patients chosen for random record reviews can be looked up in the detailed audit log dashboard by their unique patient identifier to prove e-notifications were sent in real time and by what method. The summary dashboard view provides an at-a-glance view of data sharing with community providers at a national level and can be used to surface community partners who you may want to foster closer relationships with in the future. In sum, our audit reporting feature provides hospitals with both CMS compliance survey and data security peace of mind. We talked about why PatientPing is a trusted intermediary for COP compliance, and that is really based upon the strength of 3 key factors: our network, our product, and our team. We have a world-class team of company leaders, board members, and advisors with deep experience in policy and interoperability with prior experience at organizations like CMS, Commonwealth, Epic, and Cerner. With a robust network, strong product, and world-class leadership, PatientPing is the go-to choice for e-notification COP compliance for hospitals looking to partner with an intermediary. That concludes the product section of the presentation, and I'll hand it back over to Chris to field any questions that may have come through from the audience.
Thank you, Kirsten. And there are a ton of questions coming in. Please, if you have more, feel free to type it in the question box. And while we're going through these questions, I'd also like to point out some additional resources for all you. First is the microsite that we've created. Go to adtnotifications.com, and you can certainly learn more about the rule there. You can also certainly contact us at connect@patientping.com. And if you'd like more information about PatientPing Route, you can go to the website link right there. So let's jump into the questions. And like I said, there's many questions. So let's start with this one. Do you have to get consent from patients on sharing their information?
I'll take that, Chris. Thank you for posing the question. The short answer is no. HIPAA's treatment, payment, and healthcare operations exception, or the PTO exception, really allows the information to be shared across those specified recipient types, those covered entities, without consent. Of course, as I mentioned earlier, and as CMS specifically stated in the final rule, patients' privacy, preferences, and wishes need to be followed, and notifications should only be sent if not otherwise prohibited by other state or federal laws or regulations.
Excellent, awesome. The next question, somewhat related, will patients have the ability to opt out of sharing their information?
I can take that one, Chris. While patients do not have to obtain patient consent to share data via COP e-notifications, as Vanessa just outlined in her previous response, we certainly want to support the ability for patients to be able to opt out of e-notification data sharing for any partner hospitals. We support patient opt-out in a couple of different ways. Many of our current hospital partners who keep track of patient opt-outs for data sharing can filter out those patient e-notifications on their end, and will send PatientPing in an ADT feed that has those events for opted out patients filtered out. For hospitals who want PatientPing to do the filtering on our end, we can do that in 3 different ways. If your hospitals capture patient opt-out in your EHR or registration system, we can filter out those patient e-notifications based on that field in your ADT data that will be sent to us. If your hospitals maintain a patient opt-out registry, you can send us a file of opted out patients, which we will load into our system to enable suppression of e-notifications for those patients. Finally, if your hospitals don't have an established patient opt-out workflow in place and won't by the compliance deadline, PatientPing provides an opt-out web page where you can direct patients to indicate their opt-out or even their re-opt-in preferences. In sum, we'll work with your hospitals during implementation to find the opt-out option that works best for your health system. And I should note that that can be different for different hospitals that roll up into a single health system as a whole for multi-hospital health systems.
Great, thank you, Kirsten. Another question, we're partners with HIEs. Can my HIE make us compliant?
Chris, thanks. I think it's so appropriate for me to take that. I think I would refer you back to the considerations we went through and assess whether your HIE sort of fulfills all of those capabilities. So for example, can they send notifications to the post-acute providers? Can notifications be sent in real time? Can the provider-patient relationships be updated really in real time or on a daily basis? And what is their experience like for those recipients? Can they receive those notifications? Is it a cumbersome process? What are the potential barriers there? We know sort of from our experience in partnering with some HIEs across the country that the capabilities vary. So I would really strongly urge you to make these assessments and go through those key considerations and just kind of check off what can be met. And I think that's how I want to sort of conclude that answer. Thanks, Chris.
Sure, absolutely. Some more questions from the audience. Would SNFs be responsible for e-notifications to home health agencies and hospices?
Yeah, good question on the post-acute side. So these COPs actually only put in place hospital requirements or requirements for hospitals. So there is no requirements for SNFs to send notifications on to home health or hospice agencies. So it really is self-contained to the hospital sector, at least as far as these notifications or disnotification COP is concerned.
Okay. Next question: do psychiatric hospitals discharges only go to the PCP or to the psychiatrist, to the psychiatrist behavioral health provider as well?
I'll also take that one, Chris. I think we can kind of refer back to what Kirsten talked about, and sort of what I mentioned a while back, and that is that the notifications will either go to the specific provider, so whether that's the psychiatrist or somebody else that the patient may specify at the point of care, or any other provider that has an active and established care relationship with that patient that can be matched to that patient. Now, again, especially if you talk about psychiatric patients and sensitive data that may potentially fall under the Part 2 guidelines, CMS did note that the state or other federal regulations that may be more stringent or maybe superseding those COPs that we just talked about will come into play, and that those would then take precedent over the COP requirements.
Okay, thank you. Another question. This is more related to PatientPing. Do you have to have Epic in order to receive PatientPing notifications?
I can take that question, Chris. No, you do not need to have Epic. The great thing about the PatientPing solution is that it is EMR agnostic. So we work with numerous different EHRs across both the acute and post-acute settings, and we'll be able to implement our solution regardless of the EHR your hospitals currently use today.
Okay, and I think this may be for Vanessa. Is there any further clarification around what real time means in the definition of the rule?
Yeah, so as mentioned, the rule says at the time of the patient admission or at the time of emergency department registration. So that is the definition that is verbatim in the final rule. I think, that could potentially be further clarified as part of the interpretive guidelines that are still being drafted, but for the time being, the definition and the operating assumption is real time because of at the point of inpatient admission, sort of specific language that is in the final regulation.
Okay, thank you. Another question. What about notifying the patient's insurance carrier? We had a payer telling us we would be required to notify them.
I can take that one. So the rule specifically lists the set of required recipients, and the payer is not part of that set of required recipients. So payers will not need to receive e-notifications from providers for providers to be compliant with this condition of participation.
Okay, great. This is probably for Vanessa. Is there a limit on the number of providers a patient can have their discharge information sent to by the hospital?
Yeah, I'm happy to take that. No, that's not specified. So if you have multiple providers that the patient specifies, or that have that established care relationship with the patient, there is no limit. Of course, you do need to have that. You do need to be a covered entity with that established care relationship in order to receive the information. So it's not going to go to all providers. So as long as that requirement is met, there is no limit on the number of recipients.
Okay, another question. Our medical center also has a rural health clinic with separate CCNs, and we share the same EMR system. Do we still demonstrate e-notification compliance?
So I can probably take that, and I may have you repeat some of that. So if you're under the same CCN number and roll up to that same number, I'm sorry, can you tell me again? Was it just a rural health clinic? Can you repeat that again?
Yeah, so the medical center and the rural health clinic have separate CCNs, but they share the same EMR system. Do we still demonstrate e-notification compliance? Do we need maybe more clarity on that?
Yeah, perhaps. So I believe so. It doesn't matter that you share an EMR. I don't think that's a criteria here. It would be more around whether you fall within either the hospital, critical access hospital, or psychiatric hospital designation, and then that would trigger the requirements.
Okay. Another question. What is the penalty for non-compliance with the new rule?
I can take that. So because this is a COP and will be part of that medical record services provision, it will be treated just like any other hospital COP compliance component. So there won't be monetary fines that CMS will levy on the hospital, but as you probably know, it's kind of all or nothing in terms of compliance with COPs. So this will contribute to that all or nothing compliance across all of the conditions of participation that hospitals have to meet. And any deficiencies that are found, so any parts or standards under those COPs that are not met will be noted in the form and as deficiencies, and then there are 10 days until you have to complete that corrective action plan or submit that corrective action plan. And then if that is not remediated, that deficiency is not remediated, at 90 days, there will be a termination of your CMS certification, which again means that you won't be able to receive CMS payments.
Okay. Another question. I work for a home health agency. How long will I receive notifications after we discharge them from our service?
I can take that question, Chris. So currently, for providers and home health providers that receive notifications via PatientPing through our Pings product, they're able to receive notifications on patients that they've discharged from their service up to 90 days post-discharge. So if those patients received care on any hospital or their post-acute site anywhere on our national network, that original home health agency would be able to receive those notifications via Pings for a period of up to 90 days post-discharge.
Great. Another question. Keep them coming in, guys. There's still plenty to go here. Where do the notifications show up in my EMR, or is there a separate portal used?
I can take that question as well. So PatientPing has a number of different options for by which providers can view these notifications. We have both a web application, think of it as more of like a Twitter experience where these notifications will come in a notification feed or our ping feed. We also complement that with options to receive push alerts via SMS, text, or emails. We also can support integrations directly into other software that you may be using for care coordination. So integrations into your EMR or population health software as well. Finally, we support exports. So if your provider organization wants to do a large export of notification data and do additional analysis with that data or use it for other purposes, that's another way that providers can use and consume our notifications from PatientPing.
Excellent. Another question is our small rehab hospital currently calls PCP offices about notifications and faxes DC summaries to the PCP office. Would this no longer be in compliance with the notification?
I can take that. So yes, you can certainly still continue your processes that you have in place, but faxes, phone calls, other types of communications would not count in terms of e-notification. So those are truly like electronic notifications that have to be sent, as we talked about, using the HL7 2.5.1 standards. So it could be supplemental. So if your current work could be supplemental to this e-notification process.
Okay. Let's see, another question. When should hospitals begin vetting different solutions in order to realistically meet the compliance deadline?
I can take that question, Chris. CMS did extend the compliance deadline from the initial 6 months that was in the initial final rule to 12 months in the final rule that was published in the Federal Register. 12 months is still a short time frame to make sure you're compliant in your hospital and health system. So hospitals will have to decide whether or not they want to take on compliance work in-house or work with an intermediary. If they choose to work with an intermediary, they need to leave time to vet available options. Once a vendor is chosen, hospitals will have to navigate in any internal approval, budgeting, and contracting processes, which can take a lot of time. On top of that, there's a lot of uncertainty around COVID resurgences and possible second waves of infections. So COVID burden over the next 12 months is another uncertain variable. Given all this, we really recommend that hospitals start formulating their compliance strategy as soon as possible.
Excellent. Another question. How would PACS or PCPs respond to a notification? Can they send a reply directly to the hospital system?
Currently, we do not have a mechanism for a notification of receipt back the other way. I will note that this regulation does focus on the requirement for hospitals to send notifications, but currently, no, we do not have a mechanism to send like a read receipt or those things. But hospitals will indeed have their notifications sent to all their community recipients.
Okay, awesome. So I believe that is all the questions that have been asked. And so if there are no other further questions in the last few seconds, this concludes our webinar. We thank you for your active participation. And as a reminder, you'll receive a recording of this webinar in addition to the slides itself. And as you can see on the slides right now, we invite you to visit ADP Notifications or certainly contact us if you'd like to learn more about the rule. Thank you for your time today and be safe.